Hi, lovelies. How are you? Come in here, come in here. Let's enjoy the cruise. Okay, so thank you for sticking up with me. Thank you for watching my videos. Um, if this is your first time here, you're most welcome. This is your girl Sarah, just sharing what I know about the midwifery OSCEs. So also feel free to comment in the comment section if you have any query about anything. If you need clarity on anything, feel free to engage. I'll gladly get back to you. Okay, then if you're a return subscriber, thank you for coming back. I appreciate your effort. I appreciate your support. And if it's your first time here, please, I request you to go and subscribe so that you get notifications every time I post a video. And also feel free to inquire or let me know of what videos you want to watch again. Okay, so since we're done with the birth criteria, so now the next thing is the emergency birth stations. So with the emergency birth stations, we have 3 of them. So that's the breech, then we have PPH, and then we have shoulder dystocia. So I'm going to do videos on each of them, the 3 of them. And on each 3 of them, I'll still be giving you 2 versions of how to go about it. One of them is too detailed, another one is a little bit keeping it precise. So this is to get for you to get an idea of what you want to check out more in of them. Okay, thank you for watching. Let's dig in. So we're going to start with breech birth. Okay, so and this is our marking criteria for the breech. Okay, just as you see, this is the midwifery marking criteria talk updated January 2024. Okay, remember this talk always changes. They keep updating it, so I shall always try to keep updating every time. Sorry about that. I'll keep updating every time we have their new updates that come up. I'll make sure I keep you posted. Okay, all right, so I'm going to begin with reading the assessment of the breech, and then we go into how. Okay, stay tuned. Okay, so number 1 declares the emergency, stating breech birth, and recognizes the need for assistance. Declares the need for assistance using the emergency buzzer and states calling 999 ambulance is indicated, and you can verbalize that. Okay, so that is if you're in the community. If you're in the hospital, you're going to call 222 4 times, and then you make sure you call the senior midwife in charge, the obstetrician, the why does that word confuse me? It's hard for me to mention. Anesthesiologist. That all these people give anesthesia. Their term always confuses me. And then also you call the porter and also other staff midwife. Okay. Second, you gain consent to provide care and verbalize the need to communicate the emergency situation clearly to the woman. 3, recognizes the importance of involving the woman in care planning and decision making in particular position for birth and making evidence-based recommendations for the woman. Okay, then recognizes the midwife's role in the first line management of emergency breech, ensuring maternal and fetal well-being, and that the nearly obstetric unit is unaware of the emergency. Okay, so make sure you listen to the fetal heart throughout. Okay, then 5, demonstrates the principles of facilitating a physiological breech birth safely following evidence-based practices. Hands off the breech. Okay, evidence-based practicals. Hands off the breech, supporting the woman to push with every contraction to facilitate birth. 5, articulates the importance of the fetal back being uppermost, anterior in line with the symphysis pubis. When the woman is in a semi-recumbent position, articulates that the back starts to rotate posteriorly. Articulates if the back starts to rotate posteriorly, gently grasps the fetus around the pelvic girdle. I think we all know that. Sorry. The pelvic girdle. This is the pelvic girdle. So using both hands, you put your thumb here and then hold here. Also, the other arm does the same, and then you're able to do that. Okay. Hold by the pelvic girdle and rotates without traction to ensure that the back remains anterior. Okay. Then articulates the need for timely identification of delay of more than 5 minutes from delivery of the buttocks to the head, or delay of 3 minutes from the umbilicus to the head, and delivery of extended legs and natural extended arms if progress is not made after delivery of the umbilicus and there is evidence of poor fetal condition. 7. Evaluates the need for an episiotomy. 8. Demonstrates the ability to move extended legs in a semi-recumbent position. Demonstrates the ability to remove natural arms by performing the love set maneuver in a semi-recumbent position. Articulates the need to perform Mauritius Mellivate maneuver to deliver after coming head. We all know that's Mellivate maneuver, whereby you put this finger into the baby's mouth and you do like that. Basically, this is what you're doing to the baby, right? So that the head is able to come out when you're holding that, holding the check. Okay. Then demonstrates the ability to perform Mauritius Mellivate maneuver to deliver after coming head in a semi-recumbent position. Okay. Then we have up to 15. So verbalizes that poor fetal condition at birth is anticipated and a requirement for neonatal life. Articulates the need to facilitate skin-to-skin contact between the mother and the newborn if the newborn condition allows. Articulates the requirement for contemporaneous documentation of labor and birth. So what is contemporaneous documentation? Contemporaneous documentation is like some notes you make as the, what should I say, as you carry on the procedure, because in an emergency sometimes you're going to forget some things, but you have to make sure you write everything you remember. 15. Acts professionally throughout the procedure in accordance with the NMC guidelines, the code, professional standards of practice, behavior for nurses and midwives and nursing associates. Okay, so that's it. Then something else I would also like you to look into is when you're reading for the breech. So which skill, ask yourself these things. Okay, so when you're reading for the breech, you have to put some things in mind. Okay, you're going to ask yourself, name the type. What are the types of breech presentation? During what clinical emergency is it advised for a woman not to push, and why? Okay. Then also, an episiotomy should be considered under what circumstances in relation to shoulder dystocia? Is it strongly advised to be hands-on when facilitating a breech? Definitely it's not. Which part of the baby's body should be uppermost during a breech-day birth? Okay. What are the risk factors associated with shoulder dystocia? And then during the love set maneuver, should the baby be rotated 360 degrees Is it true or false? Then, what babies should be referred to for hip scans? Then, name the 3Ds to be performed at the end of an obstetric emergency. So the 3Ds that are supposed to be performed at the end of an obstetric emergency. One is the detics. Detics. You write how the instance happened. Okay. And then documentation, and then debrief. You have to debrief the mother and also debrief your fellow staff. Remember all that multidisciplinary team that you called, you have to debrief them. Okay, so those are the 3Ds every time you're ending an emergency. So in all the 3 emergencies we are going to have, you're going to listen, you're going to hear that at the end. Okay, all right, so let's dig into the how. Okay, so just like other scenarios, one, we're going to assess the room for trips and falls. Even if it's an emergency, you should make sure it is safe. There's no shortcut to that, because if anything happens, you'll be blamed for it. You're answerable. Okay, so washards according to the WHO protocol, to the WHO guidelines, which are 8, and then you go on to you go on to put on your PPE. Then close adjacent curtains for privacy. If there are open windows, close them to make sure the mother feels safe. Okay, then you're going to go on and introduce yourself to the mother. Hi, mommy. Hi, Jamila. I'm your midwife. I'm Sarah, your midwife today. Can I confirm your name and date of birth, please? Okay, mommy. Jamila, how do you feel? Do you feel like you're going to give birth? Okay, let me check. Then, oh, mommy, your baby's coming, but buttocks first. The presenting part. Okay, then ask her, can I examine you? Okay, now I'll lift off the blanket. Is that okay? So, Jamila, your baby is coming, buttocks first. But don't worry about it. We'll deliver the baby safely. I just need to ask for some help. I'll pull the emergency buzzer. And you remember the people I mentioned, the senior midwife obstetrician, anesthesiologist. That word. What they are called, anesthesists. Pediatricians and the scrub will come. Okay. Then I'll clearly state to the team that this is a breech birth. I'll clearly explain to the mother this is a breech birth and people will be coming here. Please don't be scared. We need help. Okay. Then you call the 2222 to let those people come. Okay. So when you call the 22, make sure you state where you are. I am Sarah, the midwife in labor ward, room number this and this. I have an emergency, this and this, so that people know exactly where to go. Okay. Then you also you ask the mother, which position do you prefer? Supine, all fours. So remember, before you give the mother option of all fours, you should make sure she's able to go on the all fours. So then we if she chooses supine, then you tell her, oh, Jamila, that's okay. You are doing well. As you're pushing, I'm going to be hands off the bridge, observing your baby descending. If I notice any delay, I'll help you deliver the baby safely. Is that okay? Yes. Okay. In this point, before doing any internal maneuvers, I'm going to assess the perineum for episiotomy. Examiner, can I confirm I need an episiotomy? So you have to confirm that with your examiner. If the mother needs an episiotomy or the vagina is roomy enough that you don't need an episiotomy. So most times the examiner may tell you we don't need an episiotomy. The mother is adequately well. Okay. So So we shall go on and okay, Jamira, I noticed a delay in your baby's leg delivery. I will gently put my finger on the popliteal fossa and flex the knee and bring the leg down. We know the popliteal fossa, so you have to put this finger to pull it up. And flex the knee and bring the leg down. Again, do the same on the other side and still do the hands off and wait for the fetus to descend again. Okay, so again, I'm waiting for another landmark. Mommy, Jamira, you are doing well. I can see the scapula. So I'm going to perform a love set maneuver by putting my fingers around the groins of the baby with my thumbs over the sacrum, just as I showed you earlier. Okay, rotate the baby with the same finger on the same side as the shoulder. Then put a finger over the baby's shoulder into the antecubital fossa and flex the arm down. Flexing the arm down. So this is it. The baby's arms are inside there. So when you take in your arms, you're going to do this so that the arm sweeps over the baby's chest and you're able to deliver. Okay. So another landmark. So we are going to wait also for another landmark while the mother is pushing, and that's the nape of the neck. So after both arms are delivered, it means they're like this. So the baby is coming out. We're going to wait for the nape of the neck. When the nape of the neck arrives, it means we are ready to do our Morrissey smelly fit. Morrissey smelly vet maneuver. Oh my god. So this, you're able to keep up, and then you have to pull the baby's head down to be able to bend it and deliver. Okay, so let me read that for you. For this maneuver, it is important to rest the baby on the forearm with 2 fingers on the cheeks of the baby, with the upper hand pressing on the occiput. So this is the upper arm pressing the occiput, as this one is pulling down here to aid flexion. Okay, as the mother pushes. So after I've delivered the baby, I'll put the baby to Jamira's tummy and start skin to skin contact to help the mother bond with the baby. If the baby needs resuscitation, immediately I'll clamp the cord and transfer the baby to the resuscitator. But if the baby does not need resuscitation, I would delay cord clamping 1 to 5 minutes and then stimulate the baby and put on a hat and take off blood for the cord gases. At the end, I'll do my 4 Ds: documentation, duty of candor, ethics, and debrief. So duty of candor is you being truthful. Not telling lies about anything that happened. Okay, then I'll dispose of my PPE and wash my hands, okay, according to the WHO protocol. The examiner expects you to do that like every time. There's no halfway of washing hands. So every time you attempt to wash hands, let it be full, like full. Interlaced, interlocked. And show wrapping of the thumb, the tips. Finally, raise your hands and then go. Okay, then that's the first one. Then it's almost similar, but I believe in giving 2 versions. There is that other one that is modified. So this one I'll come. Oh, Madam Jamila, I've been told about to deliver your baby. I've been told you're about to deliver your baby. So may I please continue from where my colleague has stopped? I'm starting the other version, number 2. Okay, You find which one works for you, eh? Kasav kanyama. So I'll draw my curtains for privacy, wash my hands according to the WHO, and then put on my gloves and apron. I'll look around the environment to see if it's safe for me and my mother. Then I'll kindly approach my patient. I have confirmed that I'm having the right patient. She's Jamira, and then I'll get my fetoscope, and I know, and I'll tell Jamira, hello Jamira, I know you want to push, but please wait a bit. I need to listen to the baby's fetal heart rate. Okay. After that, okay, Jamira, the baby is okay. You can go on to do what? To push. Jamira, push, push, push. Okay, the baby's buttocks is coming. I'm going to do hands off the breech, okay? Kindly stop pushing and come near the edge of the bed. So this is an emergency. I'll quickly use the emergency buzzer to call for help, whereby I'll introduce myself as Sarah the midwife in labor suit, and I'm having a breech presentation, whereby I'll need help of the senior midwife, I'll need help of the obstetrician, I'll need help of the doctor, I'll need help of the anesthesiologist, I'll need help of the pediatrician, I need help of the scrub, I need help of other midwives who will come to help me with the delivery, okay? Okay, Jamira, kindly continue pushing. You are doing great. I'm seeing the buttocks is coming. If the buttocks is out, if the buttocks is not, if the buttocks is out after 3 minutes and you're not seeing the legs, it means the legs are extended or hyperflexed. Remember, there are 3 minutes if you need to see them. Okay, Jamira, the legs are not coming, but I'll help you deliver the baby. Madam Examiner, I will handcuff my hands into a Pringle-like manner and access the perineum if there is need for an episiotomy, and confirm with me if I have enough space and I don't need an episiotomy, okay? So I will put into my 2 middle fingers along the outer aspect of the hip, and locate the great trochanter and deliver the first foot. Then I will again get my 2 fingers, locate the thigh, but before doing that, I'll have to first locate the waistline to start manual delivery of the foot. So do the same for the second foot, okay? Hands off the breech. Jamira, you can continue pushing, okay? You are doing great. After delivery of the buttocks, we have to wait 3 minutes. If the head is not delivered, then we shall need to help the mother deliver, okay? Jamira, please continue pushing. You're doing great, and I'm seeing the umbilicus. Continue pushing. I'm now seeing the nape of the neck. Remember, I showed you the nape. So the shoulder blazes, which means the hands are hyperflexed, and I will manually deliver the hands, okay? I'll get my 2 fingers and locate the elbow and sweep the arm across the chest and put it out. I'll wait for 2 minutes. If the head is not delivered, when you do that also for the other arm. Then I'll wait for 2 minutes. If the head is not delivered, I'll put my hand under the baby's head, 2 fingers, and locate the cheekbone. These are the cheekbones. With other 2 fingers, I'll locate the baby's head. I'll locate the baby's sinsput. I'll locate the baby's sinsput and apply traction to flex the neck. Remember what I told you here? To flex the head, and I'll deliver my baby towards the mother's abdomen. Towards the mother's abdomen for skin to skin. I'll liquid clamping for 1 to 5 minutes, okay? So I also note the time of delivery, and then I'll rub my baby dry. And Madam Examiner, how is my baby? My baby is crying. Do skin to skin and delayed cord clamping for 3 to 5 minutes, okay? Clamp and cut the cord, assuming my resuscitation tray will have been organized, and my PPH tray, because the mother is susceptible to getting PPH. I will give the first dose of oxytocin 10 international units with consent of the mother, whereby I will then debrief the mother on what has happened, debrief my colleagues, and also do documentation and ethics, where I'll note the time of delivery, condition of the baby, and put off my PPE, wash my hands. Which one is easier for you? Oh my God. The main important thing is to get whatever you're supposed to do into according to the marking criteria, and make sure that you explain and the examiner understands that you understand what you're doing. Thank you so much for watching. That has been the breech delivery. So now we are going to go on to do postpartum hemorrhage. Who loves that station like I do? PPH, the two large boa cannulas, we coming in and out. We are coming for the PPH. Thank you for watching. See you. Don't remember to share and also share to others, and also let them know about the channel so that they can come and learn something. Thank you so much. I love you.